Good afternoon, good evening. Thank you so much for joining us for the Africa CDC weekly briefing. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent. And today we are joined by Professor Yap Boom, the Deputy Incident Manager at the IMST. And we also have other technical specialists with us on the call. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you, Director Margaret. Good morning, good afternoon, good evening, depending on wherever you are. We are glad that you join us for this 46th press briefing. Today, I will be taking it on behalf of our Director General, Dr. Jean Kaseya, who is currently in Malawi attending a ministerial meeting. And also, of course, thanks to all our colleagues who are in different fields fighting Mpox, cholera, measles, in all those outbreaks. I think with that, we can start our conversation. So last week has been a very intense week. We've mentioned that we had a focus on vaccination with the workload that was happening in Addis, but at the same time, we had the visit at of the AU Commissioner Ama Tun Amoa to really ensure that within the African Union, the different organ, the Africa CDC, the African Medicine Agency, AMA, who has just received the new Director General, the ALDA NEPAD, who is also the development agency of the AU, but that has a strong focus on health. So this visit was really critical to ensure that all the organs of the AU involved in health are talking to each other. The focus on coordination, to see how we can enhance the collaboration with the different organs that I've mentioned, but also to reassure that we have this shared vision, the commitment to jointly strengthen Africa health system. Next slide. Still on the alignment and the partnership, we had a visit of the Canada Secretary of State of International Development and the Assistant Deputy of Minister who have visited the Africa CDC headquarters. At the time where we are rethinking the new public health orders, different partners are meeting, discussing, and finding ways how we can align. This discussion was really focusing on the collaboration on biosafety, biosecurity, and disease surveillance. And we really support and commend actually the Canada's commitment to multilateralism and share global health priorities. And when we say that we want to move toward a healthier and safer Africa, we are also saying that it's a global investment. It's a global responsibility to ensure that all the different regions of the globe are safe, because no one will be safe until everyone is safe. Next slide. Now, this week, we see some new event as I will come later, but you can see that we keep on that increased trends where we have a higher number of risk events, high and moderate, as compared to what we've seen last year. And it's also important to remind that though we have those increased number of events, we have a decrease on the fund available to respond to them, which reminds us the call to be more efficient on the way we respond to those outbreaks. Next slide. The highlight for Mpox, we have one new country, which is Gambia. It has reported his first case on the 22nd of July. So the connection are being implemented currently as we speak with the country to ensure that we can control where they still have one case. Because the more we wait, the more the case increase and the more fund we need to respond. So we are really encouraging our teams and the Gambia to follow up the lesson learned from other countries. So since the 1st January of 2024, we have more than 160,000 suspected cases, which almost 50,000 were confirmed to have and have been reported from 27 of African Union member states. As you can see, we are reaching the 2,000 deaths among the suspected case, while we have observed 221 deaths among the confirmed case reported in 8 countries. One good news is that we see the improvement on the testing coverage. Just to remind you that the testing coverage is the number of people who are suspected of having Mpox, who will manage to collect the sample and to test. The higher the number, the better we are confident that we actually have a very good picture of what is happening in the different countries. So in the last 3 weeks, we still have those three countries that are leading, DRC, Uganda, and Sierra Leone. And you will see that in those high burden countries, we can see a decrease in the number of cases, while we have new countries that are more in the alert. Guinea is one of them, which contribute to 20% of the confirmed case reported in the week 28.
Are we referring there?
We have 7 countries that have controlled the outbreak and have not reported any confirmed case beyond the 6 week. And last but not the least, the biggest challenge as we do speak now is the fact that we have no dose available. This morning we were talking with colleagues from Liberia, we're talking with colleagues from Mozambique, and those countries are requesting to have some vaccines so that as they still have a small number of cases, talking specifically about Mozambique and Gambia that has mentioned, they can have some few vaccine to control it on top of the other surveillance activities. But unfortunately, as we do speak now, they are not available and we keep on mobilizing to get some vaccine. Next slide. For the situation in the continent, globally, we keep on observing the decline in the number of in the confirmed case, but also the suspected case. In the confirmed case, we are moving from 696 to 607. But the need to continue the vigilance, especially in the high burden countries, DRC, Sierra Leone, that I will show a bit more later. Now, when you look at what we've seen in around 6 months since from January, you can see that in terms of suspected case, we have 110%, while for the confirmed case, we have 140% of the case that we had in 2024. Case have significantly increased, but also that the surveillance has also significantly increased. And when you look at the number of deaths, which is up to 400% death than in 2024, this also highlights how critical this disease still is. Next slide. Now, we will start with those countries where we are the most worried as we do speak now. Those countries where we see an increase in the last 6 weeks. We have Nigeria, we have Liberia, where you see a significant increase. We have Kenya, and today I was talking with our RCC director from the eastern part, and she was really worried because we are seeing that the case are moving, as I will show later. We have Ghana. We also have Guinea, as I mentioned, that represent 20% of the case reported this week. So we have those countries where we see the increase. They have not yet reached the extent of Sierra Leone and others, but this is really the time where we need to have all our resource and support mobilized so that we can control the outbreak in those countries. Next slide. Mozambique, as mentioned, has reported the first case on the 11th of July. As per today, they have 50 suspected cases, 13 are confirmed. So they are deploying their response with a very high testing coverage, 100%. The testing rate is 84%. There's still some improvement, though they have managed to decentralize the lab, which means that in each province they have the capacity to do the molecular diagnostic of Mpox. The test positivity rate of 26% is quite good, showing that the surveillance in the community is happening. And as you see also with the decentralization, they have 24 hours from the time the sample is collected to the time the result is brought back. There are some improvement to do in the contact listing, as we see that we have 4 contacts for 1 case, while we expect to reach a threshold of 20. So there's some effort that has to be done on that, and our teams are working and closely. And as mentioned, we had that good discussion today to see how the IMST and other with our partners can actually support the Mozambique. The concern that was really striking today during the discussion is the cross-border surveillance. So the Mozambique is bordered by four of five countries bordering: Malawi, South Africa, Zambia, Zimbabwe. They all have reported some Mpox case, which means the country is surrendered. Apart from Eswatini, all of them has been having case. So now there is a critical need to reinforce that cross-border surveillance while ensuring that the case that we've seen already in the country are well investigated, that we increase the number of contact lists, and then in isolation, which include. Next slide. In Togo, which is another very concerned country for us because of the geographic situation of Togo, because it's a hub. It's a big hub with ASCII serving all the entire West Africa, but even more than that. So having this increased number of cases is concerning. Though we are talking about an increase from 4 to 8 cases, that's really the time where all the action has to be strengthened, has to be implemented so that the country can control at this stage, especially when, once again, when the vaccine are not available. The test positivity rate of 24% is also a good sign that the surveillance is happening properly in the community. The contact listed are 1141. We are moving in the good direction. So with some support, operational support, we believe that they will be able to get to the 20, but also to 20 good contact, because in that disease, we are talking about contact within the household, but we are also talking about the sexual contact, which are much more difficult to capture. Next slide. In Ghana, we have a slight decline in the number of suspected cases from 135 to 127. However, we can see an increase of the confirmed case from 7 to 27. So this is quite important, and again, reinforce the need to act now with the surveillance, the investigation. The country has also requested some vaccine. They are working with the NITAC to ensure that they have all the approval that they need, the AUA, so that once the vaccine are made available, they can have access to those. The most affected region remain the Western North, and the Greater Accra, and active surveillance has improved and should prioritize this high-burden region to curb the transmission. And then the tailored outreach to high-risk group, the young male, the minors, must be strengthened via the community engagement. Next slide. In Guinea, I mentioned that Guinea represents 20% of the case reported this week. You can see that 137 increased in the number of new confirmed cases. This is quite escalating. And that reminds us sadly how Sierra Leone started, actually. We were seeing the case doubling every week. So the discussion also that we have with Guinea, it's pushing us to ensure that by next week we should be in a position to support the country on intensify the response, especially the one in the community. The test positivity rate has decreased, is a good sign, but we are not yet there, that one. And also while discussing with the colleagues, they have those challenges that they've mentioned with patients escalating from the hospital, sometimes because they need the holistic care, which needs some fund, and also some of them have not been counseled sufficiently. That's why our RCC colleagues are really trying to engage with the country, trying how they can support to reduce the stigma on one side, but in the other side to ensure that the right information is being given to the patient. They need to be isolated as a way to protect them, but also to protect the community. Next slide. So in Kenya, we can see the increase in the number of suspected cases by 100%, and the new confirmed case as well. From 16, this week we have 27. And the most critical thing is that the transmission was initially concentrated along the coastal corridor. And now it is spreading inland in the western part of the country, for example. And this is quite worrisome because when you start moving out of the first area, then the case can really escalate. The country has received some vaccine, I think 10,000 doses. They are in the final stage of the planning, the micro planning, and we believe that it will be a good stimulus to limit the transmission. But again, we emphasize that vaccine is one thing. The other critical thing is the surveillance. So when we see that we have two contacts for one case, we are really far from what is needed. Remember, we think of 20 contacts for one case. So it does really need to strengthen that community-based surveillance with some support, because this community-based surveillance is quite costly. So countries are mobilizing their resource, and then we are also supporting, finding ways how we can get support to ensure that they implement the response as soon as possible and the way it should be implemented. Next slide. In Sierra Leone, we are glad to see the plateau that following that reduction. So this week we have 125 to 21 cases, as we did have last week, though the number of suspected cases was a bit higher. The testing coverage remained high, 100%. We keep seeing the decrease on the test positivity rate, which is definitely a product, a benefit of the community healthcare workers who are every day in the community, in the house to house, seeing the community, seeing the patient, communicating so that the stigma around the disease can decrease, but also encouraging the patient, those who have symptoms, to actually declare them, and also, more importantly, to be able to mention the contact so that we can also be able to include them, one in the vaccination, but other two on the isolation. So there is a need to strengthen the compliance with admission protocol, which is happening in new treatment centers. So Sierra Leone is really a country on top of the other where we are really trying to follow and ensuring that the decrease we are seeing is a true decrease, so that we don't have any surprise in the next weeks. Next slide. In DRC, we are also seeing a decrease, both in the suspected case and in the confirmed case. You see the decrease in the confirmed case is 64%. We are moving from 176 to 62 with zero death. We can also gladly see that the testing coverage keep on increasing, around 51%. The test positivity rate also has decreased to 35%. All those are definitely sign that the intensification and the surveillance is. However, we should also be very careful on ensuring that the surveillance keep happening, not only in Kinshasa, but in all the different provinces, as we know that the eastern part of the country, despite the humanitarian crisis, it's remained one of the top part of the country where we have the highest numbers of cases. So we are glad to see the decrease, but we remain very vigilant to ensure that we keep on capturing all the suspected cases and the confirmed case. Next slide. In Burundi, we see now this week that small reduction on the number of suspected cases and the confirmed case, which is reassuring, because we were seeing the number of cases increasing, and the government has decided to re-stimulate the response with community healthcare workers going back in the community to remind to the community that Mpox is not over. So the best practice that they've been using in the beginning should carry on. So that is critical, especially at the time where we might see the fatigue of the outbreaks. So we have the case that have declined by 80 0.6% from the week 43 to the week 27. And that has also been supported by the decentralization of the laboratory, of the patient management, the isolation, and so on. So all those good practices need to be continued until we really get to the time where we have zero case in some of those places. People are now remain the most affected districts. So this is really the place where the Ministry of Health with all the partners are focusing and ensure that the active surveillance and the investigation are happening so that we can really confirm Burundi as a great example on the Mpox response. Next slide. Malawi, where the ministerial conference is happening, we are also glad to see that the case remains stable with a small decrease. They have reported 50 confirmed Mpox cases due to the clade 1B, primarily in Lilongwe. And the affected individual include mainly the student, the business person, the drivers, the sex workers. So population who are quite mobile, if we can categorize all of them. So the support is being brought to the country in terms of diagnostic, in terms of IPC and others to ensure that we don't move from there, so that we keep on supporting the country to ensure that they keep that good surveillance. We can see that they have 13 contacts per one case, which is quite good, though we are not yet at the rate of 30. Next slide. Uganda, it's another one of the key countries that we have been following, because at some point we were happy actually to see the decrease of the number of suspected cases and confirmed cases until we support the country for the community-based surveillance, and there the case started to increase. Now seeing the decrease is encouraging. Also seeing the decline in the test positivity rate, showing that yes, the surveillance is happening well in the community. And two, if the cases are decreasing, most likely it's a true decline in the number of cases. So the surveillance has to continue being strengthened along with the vaccination. The country still have 97,000 vaccines that are available, planned for the next round. And we believe that the next round will be, as the country did it well, targeted to the hotspot, to the key population, so that we can keep on seeing the decrease and we go to the level where we have less than 10 cases per week. Next slide. In terms of vaccination, the Sierra Leone will receive 50,000 of vaccine for the last allocation, and this will be the delivery of the last dose of vaccine that are available. Though, as you've heard me mention, many countries, Ghana, Liberia, also need more vaccine. We have Gambia, we have Mozambique. The need is there. The vaccine, in terms of availability, are also there with the manufacturer. I think 800,000 doses are available in the shelf of Bavarian Nordics. What is missing is the fund to procure those vaccines and to ship in countries where they are needed. In the other hand, the research and innovation is giving us some solution, the fractional dose, which will be an opportunity to use one dose for 4 to 5 patients. So we believe that once the vaccine will be available, the experience of vaccination that country have shown and the use of fractional dose will really help us to scale up the vaccination in countries and therefore control faster this outbreak. And next slide. Now, moving from Mpox to cholera, though some of the country are the same, the DRC, Sudan, South Sudan, Angola, where we see an increased number of Mpox cases, they also are dealing with cholera. And as we see also in the number of deaths, you can see that we had 4,000 deaths in the week 28, reaching a total of 197,000 total cases. So the cholera situation is really alarming, though you will see there are some decrease in most of the country, and DRC remain really the most concerning country as we do speak now. Next slide. In Sudan, we see a decrease in the number of cases, as you can see, almost 34%. We see an increased number of deaths, but that might not actually be that we have all those deaths within that week, but sometimes the data harmonization, the backlog, bring us those high number. So in terms of vaccination coverage, as you can see, is still very low, 5.6%. And the main challenge with Sudan, as we also see with South Sudan, is the responding to an outbreak in the conflict-affected area is really a challenge. So it's another opportunity that we have whenever we can to remind that there is no health without peace. And then we really need our leaders to move toward a peace as we also work with other humanitarian actors to ensure that we have the opportunity to reach the unreachable population. Next slide. In South Sudan, we see in the other side an increased number of cases and also on death, especially coming from new area, Robkona and Mayendit counties. That will be investigate with the support of Africa CDC next week. The vaccination efforts are actually progressing well, and they were having 10 million doses of vaccine available. Now with 2.5 million remaining, they will locate the critical zone, the hotspot, Unity, Jonglei, Central Equatoria, North Bal, El Ghazal, and Upper Nile State, where we'll need to implement the last mass vaccination, and also the surveillance that goes around the response to cholera, which it's important to remind, it is not only a health response that we need. It's really a multi-sectorial approach. And in this context, we also need the humanitarian or military support. Next slide. In Angola, the case continued to decrease, 996 versus 260 last week, with only one death reported as compared to 4 last week. A very good vaccination coverage with almost 99%, so almost 100% of vaccination. And you can say that when you have all the tools necessary to respond, we can get there. We can really see the decline continuing. We have the vaccine, we have the political will, we have the opportunity to respond. We don't have the same challenges in terms of conflict and so on. So this is also something to commend the Angola for the response to cholera. Next slide. Now, from those countries to DRC, which is showing a different picture, though this week we are happy, or we are encouraged to see the decrease, both in the number of cases, but also in the number of deaths. We are moving from 124 deaths last week to 81 deaths. It is quite encouraging. So the hotspot for the last 3 weeks are the Tropo, the Sud Kivu, and Kinshasa. I will come to that. Remember, Kinshasa being the capital city also emphasized some higher risk in terms of the spread of the disease. So the vaccination has started. This is a key element, as we've just seen in Angola. So here, 11 health zones in 4 provinces, the Tanganyika, the Maniema, Okatanga, and Tropo will receive the vaccine. The challenge in water supply in many health areas like Goma is a critical challenge, because when the water is not available, you can imagine that the population will take whatever is available, and whatever is available, unfortunately, is the key driver of cholera in those communities. Next slide. So as mentioned, you have all those, all the part of where you see all those red dots. You see the Tropo, the South Kivu and Kinshasa, and one of the connection with all those are the river. And again, highlighting when the water supply is not available, people will go to those rivers, and the cholera will be spread through the river, and population will keep on being contaminated. So this is a good example, if needed, to see how impacting the way population can have access to water. And you can see the disruption that are happening in Goma, which definitely affected the place. But also we have 1,466 latrine holes in former displaced persons see that need to be emptied and backfilled. And if those ones are not, then they will keep on contaminating the water and population will keep being affected. Next slide. In Kinshasa, the capital city, the case and the death are decreasing from 304 cases. We have seen 271 cases in Kinshasa. This is still very high because it means that the disease keep on spreading. The deaths as well are reducing, which is a good sign of the case management that is being put in place with the support of partner and the great leadership from the Minister of Health. So in terms of hotspot, we have the camp around Kokolo, we have Limete. And if you do remember, Kokolo, Limete, Bumbu are also the same high hotspot for Mpox. So it's really that big challenge of managing those different outbreaks. But behind that, it's definitely an issue of poverty, of an urbanization. So remember, re-emphasizing the need to have a multi-sectoral approach so that while we are taking care of our patient, while we are preventing, while we are doing surveillance, we also need to have the infrastructure so that water can be available, so that we can reduce the promiscuity. That is a key driver of the two disease in those communities. So 33 health zones in Kinshasa affected, with Kokolo mentioned having the highest burden. So the long-term response is needed. It's not only responding to this outbreak, but really finding the ways to address the fragile wash infrastructure. This is what is needed in DRC. This is also what's needed in all those countries, so that beyond this current outbreak, we really prevent the outbreak that are seasonal because of the flooding, because of the impact of climate change. Next slide. So in summary, the Mpox continued to expand, reaching new countries. Today we've been talking about Gambia. Last week it was Mozambique that are being affected now. We have a part of the high burden countries where we see the decrease, the DRC, Sierra Leone, while we have the increase in other countries, Nigeria, Liberia, Zambia, Kenya, and Guinea, which once again reported 20% of the case last week. The community-based surveillance is improving, it is key, and it is costly. So countries are really challenged on the getting the necessary fund to be able to track the disease in the community where it is, and to implement the targeted vaccination that is needed. And for the vaccination, some countries still have the vaccine. They are doing their best in terms of strategy to reach the right population. Others are in needs, but as we speak today, we don't have any dose of vaccine available, though it is there, but we don't have the fund to buy them. Cholera burden continues to decrease in Angola, South Sudan, and Sudan. This is a good news. Slightly also in DRC, though we have Kinshasa, Chopo, who are still quite concerning. So the Mpox and cholera intervention are being jointly responded in those countries that I've mentioned. And then we really commend the leadership of those Ministry of Health, the NPH, all the actors that are currently fighting those diseases at the same time. Over to you, Dr. Margaret. Happy to answer some of the questions.
Thank you, Prof. Let's get the first two questions. We cross over to the floor. We have Emery Makumeno from BBC. Emery, you have the floor. Emery, if you can hear us.
Hello, can you hear me?
Yes, we can hear you. Go ahead.
Yeah, I think Doctor covered my question. I was wondering the situation in Kinshasa in terms of cases and what is really being done in terms of prevention, apart from health centers that have been opened here and there.
All right. Thank you. Let's take the next question. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello there.
Hello, go ahead.
Thank you. Doctor, you mentioned or last week, we had 8 countries that had put under Mpox under control, according to the presentation. And today, I noticed it's 7. I wanted to know which of the countries have fallen back. And if I may, just quick one, the new case in Gambia, what more do we know about it? Like the patient, where is it from, their travel history? Thank you.
Thank you. Let's take the next one before Prof comes in. We have John Songo from Radio Pan-Afrique. John, you have the floor. John, if you can hear us. John, can you hear us?
Oui, monsieur. Merci pour la question. Oui, vous me suivez?
Yes, proceed.
D'accord. Merci pour la présentation du docteur. Ma question se rapporte d'une part à la ville de Kinshasa et d'autre part aux villes de Goma et Bukavu. Pour ce qui est de Kinshasa, il s'observe une sorte de réticence communautaire qui est qui se traduit par une sorte de doute. C'est comme si la communauté doute que le choléra soit en train de sévir dans la ville. Je voudrais savoir si le CDC, en collaboration avec les autorités de Kinshasa, a déjà analysé ces cas et proposé, pensé de vulgarisation de la maladie et de son danger auprès de la dite population. Pour ce qui est de Goma et Bukavu, les autorités en place, donc les autorités du M23, ont instauré un salon obligatoire, donc des travaux communautaires obligatoires. Et à l'issue de ces travaux, il y a les immondices sont stockés pendant de longs jours dans des ronds-points de Carrefour. Et il y a d'ailleurs un spécialiste en santé publique qui a alerté que cela pourrait engendrer malheureusement des maladies. Alors, il en est de même pour Bukavu. Je voudrais alors savoir si Africa CDC, avec ses équipes qui sont sur le terrain, essaie d'analyser ces cas et ont déjà essayé de rapprocher les autorités du mouvement M23 pour essayer de leur prévenir de ce qui pouvait atteindre la population comme danger. Merci beaucoup.
Thank you. Back to you, Prof.
Thank you, Margaret. So I will make a comment on the question of Emory, though he got the response, and I will respond to John, and I will let Dr. Messi talk about the new country that was in control. I think is Cameroon, and also the case in Gambia. So Emory, yes. So you get it all, but just to reemphasize that the community healthcare workers are really on the front of the response to those outbreak. And today and tomorrow we have the visit of the new regional director of WHO Afro, who's also coming to emphasize the political will that we as the IMST need to push in responding to those Mpox, but also cholera outbreaks, which is escalating in DRC. So, John, merci pour les questions sur Kinshasa, Goma et Bukavu par rapport à la réticence communautaire. Donc, je dirais que nos agents de santé communautaire qui sont sur le terrain, du fait de leur bon ancrage dans la communauté, permettent de faire remonter beaucoup d'alertes. Donc là, on se rend bien compte que les alertes de choléra augmentent beaucoup plus vite que celles de Mpox en ce moment. Ce qui veut dire que les populations adhèrent à cette communication et à cet engagement qui sont critiques. Donc les réticences, nous ne les voyons pas autant, mais qu'à cela ne tienne, la semaine dernière, les professionnels de la communication se sont réunis avec toutes les différentes agences autour du ministère de la Santé pour voir comment on peut renforcer l'intégration de la communication et l'engagement communautaire pour toutes ces différentes maladies qui arrivent en même temps, le choléra, le Mpox, la rougeole et les autres. Donc, dans leur stratégie, c'est aussi le but de voir comment on peut mieux équiper les communautés pour, lorsqu'il peut y avoir ces réticences, qu'elles puissent être levées. Donc, pour ce qui est Bukavu et de Goma. La première chose, c'est de rappeler effectivement qu'il n'y a pas de santé sans paix. Ça, c'est le premier message. Le premier message, c'est que ce corridor humanitaire qui nous permet de pouvoir évoluer est critique. Premièrement. Deuxièmement, effectivement, le fait d'avoir des immondices, des poubelles qui sont stockées, c'est un risque majeur. Un risque majeur, surtout quand il y a des pluies qui arrivent. Donc, nos collègues, les épidémiologistes, agents de santé communautaire, sur le terrain, travaillent dans ce sens-là, de pouvoir permettre aux communautés, d'un côté, d'avoir l'information sur les risques, mais également aux autorités en place. Mais surtout, cela rappelle que cette partie n'est pas l'une des missions de la santé. C'est une des missions de la planification, des finances, pour pouvoir s'assurer qu'on puisse répondre à cette deuxième partie. Donc, c'est une discussion, mais et on l'espère que les récents accords qui ont été signés nous permettront de pouvoir nous déployer de manière plus facile pour permettre à nos différents partenaires de déployer la réponse et d'assainir les différentes villes de Goma et Bukavu. Dr. Cheng, over to you for the question for our brother Kemo.
Thank you so much, Prof, and thanks so much, Mr. Kemo, for that question. Regarding the country, like you mentioned, it's Cameroon, and as you know, most of the cases in Cameroon historically reported are more zoonotic in nature, more or less spillover from spillover from animals. Regarding the Gambia, we received reports on the 22nd of July on the confirmed cases, just a single case. However, we have very limited information as regards the travel history of that case because there's currently ongoing case investigation that we hope to receive feedback from our focal points in the coming hours. But we also have also heard from the country that they're doing quite well in terms of intensifying case search, as well as improving contact tracing and community engagement, just so that they don't miss out on the opportunity to contain this case at source. And lastly, just to also mention that the plate type or lineage has not been revealed yet because there's ongoing sequencing. I'm hoping that in the coming hours as well, we're going to know the clade type that they have reported in the country. Over.
Thank you. Let's take the next question. We have Gabriel Emmanuel from NPR. Gabriel, you have the floor.
Thank you very much for this. I missed the very beginning, so forgive me if I've already answered this, if you've already answered this, but I had two quick questions. One, I'm curious about, we're kind of getting close to the 1 year since you've declared Mpox an emergency on the continent, and wondering if there are kind of lessons learned or things that you take away from this past year. And the second question is, last week the U.S. Made sure did not cut additional money to PEPFAR, and I wanted to see if you could comment on your thoughts about where the HIV/AIDS epidemic is going in the future and what it will look like given where PEPFAR is now. Thanks so much.
Thank you. Back to you, Prof.
So thank you, Gabriel, for the two great questions. So yes, for the last year, we've had lesson learned in all the different pillars. We mentioned last week we had the vaccination workshop where the different member states were sitting down and to see what have we learned, what is the most efficient way to vaccinate. That is one of the critical to ensure that the vaccination is really targeting the population. That's one.
Hello, Prof. We lost
significantly on the role of the community healthcare workers and the need to digitalize the surveillance so we can have real-time data that allow us to be agile and go where the outbreak is out. Not the least, there are quite a number, and I will just emphasize latest one, which is the laboratory, the decentralized. You can hear me?
You got stuck at some point.
Can you hear me now?
Yeah, we can hear you. No, you're off.
Can
You
you
went off at some point, Prof. We can hear
Okay.
you now. Yeah.
Yes. Okay. So I was saying that there are quite a number of lessons learned from the surveillance, the vaccination, the lab decentralization. But what we've also learned amongst all is that different countries have different solutions. And that we cannot use the same solution that works in Burundi to implement the same thing in Uganda. But as we move toward the legacy of this outbreak, it's also the time where we will pause as we move toward the end and really take the great lesson. So on the other question on the USA that did not cut the PEPFAR, this is a good news that we really welcome in the Africa CDC, but there's still some conversation to happen so that we can assess exactly what will be the impact. So it's a bit premature for us to really know how it will change, but the good news is that the countries since the cuts have also been a bit more resilient, and this news will also allow us to find out what is the real impact. So we'll come back to you when we have a bit more detail. Over to you, Director.
Thank you, Prof. Let's take the next question. We have Kumba from Gambia Daily. Kumba, you have the floor.
Thank you very much, Madam Margaret. Thank you, Professor. My question will be, is Africa CDC looking into planning of sending additional technical support to the Gambia following the case detection? That's my first question. And my second question is, what immediate steps are you being taken at Africa CDC level in responding to the confirmed case in Gambia, such as is there any contact tracing details that you've done, risk communication, or even isolation protocols? What do we expect after we detected such a case, so that when we write reports, it will help allay fears from the public? Because public in the Gambia are scared of, Mpox. If there's pictures all over are circulating on the social media, the way the victim is full of this Mpox on the body, people are scared, and then we will want to know from health experts, including Africa CDC, obviously, to tell us what remedy measures or resolutions are put in place to ensure that this is the only case for Gambia. And also, what are the other means that you will want to look into regarding Gambia being surrounded by other regional countries? What are the other means to ensure that it stops to this one case? And then if there is any details about the patient's travel, obviously that has been mentioned earlier, that there is no detail as of now regarding the patient's travel history or possible exposure. So I would want to know about these details. Thank you. Back to you. Thank you.
Thank you. Prof, back to you.
Yes, I will respond to the first one, and I will let Dr. Cheng's answering the two other questions. So it's the opportunity to remind that Africa CDC is co-leading the IMST with WHO, which 28 partners. And our role is really to ensure that we have a coordinated approach, a coordinated response to countries, one. Two, that the solution depend in the context and the countries. So the first thing that we do, when we have one case of more in the country is to engage the country, to understand what is happening, to understand what is available, what is needed. It is based on that conversation that the different support will be implemented. This conversation has started, and I will let Dr. King also talk about the different points that you've asked, which will give more light on what we are going to do. Dr. Chen.
Thank you so much, Prof, and thanks for that question. Really, we are happy that it's just a single case, and this is an opportunity for us to contain at source. So what we have been doing at the continental level is engaging the country to understand what current efforts have been put in place. And like I earlier mentioned, the country is doing quite well in terms of contact tracing, active case search, community engagement, and they're putting out the risk communication messages just so that the communities and the population is aware on what preventive measures to adopt. So that's one of the things I'm really applaud the country for that. But from the continental IMS side of it, what we're doing is we're already looking at deploying community health workers just so that we can intensify the surveillance and make it more active. Because if you would look into how this case was detected was mainly through a passive surveillance system. So the case was detected through just the routine surveillance. But again, given that it's already an outbreak, we need to activate the surveillance. So there's more or less an active surveillance ongoing and ensure that no case is missed. So we will be supporting the country in the coming days. We're putting together the different logistics and procedures in place and hoping that we'll get them deployed soon. And just to also highlight before I drop the ball is we don't want to replace the countries. So we are there to support the country, but not to take up the role of the country to do the actual work of going to the communities to do the active case search or do the door-to-door mobilization. We just provide the support that it takes for the country to be able to do that work. So Africa CDC, WHO definitely is not replacing the Ministry of Health in the response.
Let's cross back to the floor. We have Lucia Blanco from Spanish News Agency. Lucia, you have the floor.
Hi, how are you? Can you hear me?
Yes, we can hear you. Go ahead.
Okay, well, thanks so much for your time, first of all. And I wanted to go back to the vaccine issue. As you said last week or 2 weeks ago, you've already highlighted that there's no vaccines, but I would like to know a bit more about it. Like when you say that there's no vaccines available, you mean like no more vaccines are being committed by any country, by any organization? You also made reference to the 800,000 vaccines, which we read yesterday or the day before. There was a letter in the Congress in the States complaining about the possibility that those vaccines might expire. I wonder why those vaccines haven't been sent if they have already been promised by the US government. Is it because they promised the doses but not to pay for the shipment? Like, if you can provide a bit more clarity, like are not any more vaccines being promised? Is it about sending them? Just maybe more details about it. Thank you so much.
Thank you. Back to you, Prof.
Yes, thank you, Lucia, for this great question. First of all, a year ago, we were expecting not more than 20,000 doses of vaccine, then 200,000 doses of vaccine that could be made available to respond to the Mpox in the continent. In 2022, the large outbreak, global outbreak, Africa did not get any vaccine. So we were moving from a period where we had no vaccine to a period where we were thinking that we could have a very small number of vaccine available for the continent. And from there, we've managed, and I say we, is the IMSD and the countries, to move up to 3 million doses of vaccine that has been shipped to the continent. 1.5 million from the Japanese, specifically to DRC, but then we have 1.5 million doses that came from different countries. Spain, for example, they went in the critical stockpile of vaccine and they took some few, some few to actually support the response. Some went to Uganda, others to Sierra Leone, and so on. So just to have in mind that the dose that has been made available are countries that took from the stockpile to give to the continent. That's one. Now, on the side of the manufacturer, Bavarian Nordics, as we do speak right now, there are 800,000 doses that are in shelf. Half of them were booked, we can put it that way, by UNICEF. But booked now, they have to pay for them. Those 33 million are not available for them to procure those vaccines and therefore send them to the country that are on needs. Once the fund, the money is made available, we can have access to the vaccine that are available to the manufacturer, that one, but also countries that still have some stockpile can go back and say, okay, what do we have as critical stockpile? And then we give to countries that are in need now. Because the concept of the critical stockpile is we keep them for when we will need them. But right now, there are other countries, other people that are in need. So there is an extra effort that we are asking them. Now, going back to the US government, the pledge was 1 million. Out of the 1 million doses, 90,000 was shipped to Africa, Nigeria, Rwanda, and a bit of DRC. So, and unfortunately, for vaccine to be shipped in a country, they need to be shipped when they have at least 6 months of shelf life. And because of the change of administration, because of the freeze that was eventually lifted but not finalized, some of those doses, half of them have actually gone beyond the shelf life, so they can no longer be sent to the continent, which is a huge loss because that one dose of vaccine is $100. So you can imagine the use loss. There are some around 300,000 doses that are still remaining, but there are some lengthy conversations that are ongoing, and we hope that they will be done as soon as possible, so that countries like Guinea, like Mozambique, like Liberia, all those countries that are in need can actually have access to those doses of vaccine. So it's an emergency, but it's also reminding the global responsibility, because it's not acceptable to have some dose of vaccine expiring in one side, while in the other hand, they are really in need. So this is really a big challenge of equity.
Thank you so much, Doctor. So let me just to make sure I got it right. So right now, as of right now, the number of vaccines, the doses available are 800,000.
At the manufacturer, Bavarian Nordics, but then countries,
those are not the manufacturer ones are not the US ones. Those are two different.
Not the US one. Yes, not the US
okay.
one.
So there are 800,000 available vaccines by Bavarian Nordic, and there's just not funds to send them. And then on the other hand, the US had 800,000 vaccines, but half of them, so 400,000, are not, they are expired. So they are not usable anymore. Is that correct?
Yes, so for the US, we might be around the less than 300,000 that might be available. But also now, what we don't know is the other countries that may still have some vaccine in their stockpile. This is not information that I do have, but they might have, and they might be at the time we are discussing. Last time we were discussing with the director of ERA, who was supporting the AU, who is continuing engaging some countries, and then Cyprus and others are thinking on how to go back to the stockpile and to see which extra effort they can do.
Okay, so as of right now, the available and not expired vaccines would be 800,000 from Bavarian Nordic and around 300,000 from the States. Those are the not expired available vaccines as of now, right?
Yes, for what you have as information.
Okay. And just another question following up, in the Bavarian Nordic ones, where are they sitting right now, and why? Like, so the company offered them but didn't offer to pay for the shipment. Is that right? Is that correct?
No, at this stage, we don't talk about issue of shipment. We are really talking about the issue of acquiring the dose. So half of them, the 400,000, were booked by UNICEF. So those are UNICEF those that are kept there, but now they need to pay for it. Once it's done, then they can ship to the countries.
Okay. And the other 400,000 haven't been booked, and there's also no funds to pay them.
Exactly.
Exactly. Okay. Okay. Thank you so much.
Thank you, Prof. We have the last question that's in French. It's on your chat box.
I see Charles from the vaccine pillar who would like to add something. Over to you, Charles.
Thank you so much, Prof. Yap, for the wonderful response to those questions. So maybe just to provide a bit of clarity, with 800,000 doses available within the Barbara Nordic warehouses, of which UNICEF does currently still have about an LTA agreement of close to about 400,000 of those doses, but then it requires funding for it to go out, which is what Prof had mentioned. It could require between 25 and 33 million USD to move those doses. That is when you include both the funding, the cost, the shipment cost, and the likes to move them to the country. So those are still sitting within the warehouses. However, for the USG doses, currently we have just about 219,000 of those, and as Prof mentioned, just below 300,000, approximately 219,000 doses of the USG doses that has more than 6 months shelf life are still available for allocation to countries. But most of the bureaucratic issues we've been having is the time lag it takes to get the authorization to move these doses to the countries. And we do hope that we may be able to get this done on time, so we still do not have these doses falling below 6 months shelf life, thereby losing it all, from the pool. Yeah, I just wanted to provide that clarity at this point. Thank you so much, Prof.
Thank you, Charles. And I see the question in French, so which is from RFI. La Guinée et désormais la Gambie, la situation vous semble-t-elle sous contrôle ou y a-t-il un risque d'extension régionale? Et l'Africa CDC recommande-t-elle des mesures spécifiques de prévention aux États concernés? Effectivement, la situation qu'on voit aujourd'hui en Guinée, surtout, qui représente 20% des cas de Mpox qui ont été reportés cette semaine, est effectivement une préoccupation importante avec des risques d'extension dans la sous-région, sachant qu'on a la Sierra Leone qui est pas loin, qui a eu une escalade. Maintenant, c'est la Guinée. Le risque est certain. Pour le moment, les cas sont concentrés à Conakry et Kindia, mais le risque est véritablement qu'il y ait une transmission des cas dans tout le pays. Donc, c'est pour ça que les discussions avec le pays pour pouvoir apporter un appui en termes de surveillance, en termes de prise en charge, sont critiques. Mais l'un des atouts de la réponse, qui sont les vaccins, ne sont pas disponibles aujourd'hui pour un pays comme la Guinée. C'est pour ça qu'on mobilise également pour qu'on puisse avoir des doses disponibles pour ces pays. Pour ce qui est de la Gambie qui a reporté son premier cas, les stratégies sont d'appuyer le pays pour qu'au moment où on a ce petit nombre de cas, que soit renforcée autant que possible la surveillance, la prévention et le contrôle de l'infection, mais également la prise en charge et l'isolement des patients, ainsi que la communication. Parce que quand on a un cas, il y en a certainement d'autres. Et en général, les personnes ont peur en termes de stigmatisation et ne vont pas reporter leurs symptômes. Donc, il est critique d'avoir cet engagement communautaire pour que la situation puisse être sous contrôle. Donc, aujourd'hui, au moment où on parle, la Gambie, avec un cas, doit avoir un appui important pour le contrôler à ce niveau. La Guinée, on voit une escalade de cas à Conakry et à Kindia, et il est critique d'accélérer la réponse et le soutien à ces pays. Over to you, Director Margaret.
Thank you, Prof. And with that, we have come to the end of the briefing this week. I'll hand over the floor to you for your closing remarks. Over to you.
Thank you, Margaret. Thank you, Charles. Thank you, Musoka. Thank you, Tieng. Thank all the colleagues who are in the field for Africa CDC, WHO, IMST, and all the partners responding to Mpox, cholera, and all those outbreaks. And thank you so much, really, to the journalists that are making us accountable to them, to you, the journalists, but also to our communities, to our leaders. With your question, we ensure that we provide the right support to the member state, to the community, so that we can come to the end of those outbreaks and to have more resilient health system. With that, I thank you, and then we'll be happy to see you next week at the same time. Thank you.